Have a roll call, so we don't need to do roll call?
No, Genesis from our office will be checking on our participant list and making sure everyone is present.
Excellent. Okay. Well, welcome everyone to our second meeting of the Over-the-Counter Birth Control Collaborative. So Aaliyah Horton and I are very happy to welcome you all back and see you in this meeting. So my job is to just provide the welcome and a quick overview of the agenda, and then we'll jump right into the items. So today we're going to just get some clarification from Aaliyah on one point on a question that's come up. And then we have a couple of draft recommendations to discuss for the interim report, which is due very soon. And then we will take any questions and wrap up. So with that, I am going to turn it over to Aaliyah for the first topic.
Hi, good afternoon, everyone. Thank you for being here. The first item that we have on the agenda is responding to the questions that came up about age restrictions on over-the-counter birth control. So just wanted to give some feedback on that. One, regarding Plan B, there is no age restriction on access to Plan B. There was one, it's no longer there. So clarification there. And then in general, over-the-counter birth control has no age restrictions. So it's all clear, full access. And I believe there's some documentation on that that Brett will share for you all. But yeah, you can go in, ask for it, and you should be able to get it. And I know that there are some questions in terms of, you know, some providers keep things behind the counter and that sort of thing, but it has full access. I don't know if there are any questions from the group or anything, or we can go on to the next agenda item.
Not seeing any hands raised. Is there anything in the chat that I don't see? Victoria has a hand raised. Go ahead, Victoria.
You have to unmute.
Victoria, can you hear us?
Can you hear me now?
Yeah, yes, go ahead.
Hi. Just wanted to add just a little bit of context around that. EC was originally not supposed to have an age restriction. There was political interference that caused that, and age restrictions create barriers not only for young people, but anyone who doesn't have an ID, because it requires people to show their ID. So would strongly suggest not putting that in any sort of recommendation that we have. And OPIL was approved without an age restriction due to all of the evidence that supports adolescents having access to contraception and people having access at all ages, and young people testified to make sure that that age restriction wasn't put in place for OPIL. So just wanted to add those two things.
Thank you for adding that context. I know it comes up all the time. People make a lot of assumptions, but I'm glad we're here to be able to clarify that, and you provided the additional information. Are there any other questions or comments? Looks like Samantha.
Samantha. Oh yeah, go ahead.
Just wanted to further support Victoria's comments that Maryland has strong minor consent laws, and per our family planning administration, there are no other age restrictions. So I think it would be important to share that there is well-established precedent here to expand access as broadly as possible.
Thank you. All right, I said we'll keep it going then. I will go ahead and get into these recommendations. Just as an overview, the recommendations that we're going to talk about are a reflection of what we discussed at the previous meeting. Just like the conversation about the age restrictions, we wanted to address that. And these recommendations build on the conversations that we had as well. And as we discuss these recommendations, if they're approved, they will be included in the interim report that will be submitted at the end of this year. And then, as the note says, there's more room for nuance and specificity. This is really just to provide an update and sort of next steps, but we are going to get into more detail as we work through the task assigned to us, as we have, I think it's a 3-year appointment to get this work done. And so we have time to work through a lot of the details. So I will get into the first one. And so the first one really came from a feedback from the pharmacy community, and I believe this is why I was tasked to discuss this one. And the recommendation is that state agencies, including the Maryland Insurance Administration, Department of Health, Medicaid program, and state employee health program should advance guidance to pharmacies, pharmacy benefit managers, and health plans regarding a consistent billing method for insurance coverage of OTC contraceptive products. And so as we look at this, this is for us to provide guidance on the next steps. And we want to make sure that there's consistency across the board and for access. So no matter how a person seeks to get this, the billing process is similar across the board. And so the recommendation is to ask these agencies to provide this guidance and to support education of stakeholders in implementing the practice. And so that's what we have. So open to any questions, comments on that. Looks like Victoria has her hand raised.
Can you hear me?
Mm-hmm. Go ahead.
My hand was left over from the
Oh,
last time. I
okay.
do have a comment, but I just
Okay.
I don't want to take up too much space. So if someone else has a comment first, happy
You're
to let
it
them
for
go
now.
first. Okay. I think my comment is just that this is something that we also heard from pharmacists engaged in our OTC implementation collaborative, which we engaged pharmacists and state advocates in for about 18 months and developed some recommendations around this. The pharmacists have a really hard time processing claims if they don't have clear guidance on how to do so. And so this type of recommendation would be really helpful. I think that there's an industry norm already that sets kind of a standard around this. CVS Caremark set a standard by issuing a bulletin shortly after OPIL was launched that did issue guidance on this and did a billing protocol on this and recommended that or provided guidance that pharmacists use the pharmacy NPI number. And this will be, not only helpful, I think, in Maryland, but the 11 states that have OTC coverage if there's guidance on pharmacists using that pharmacy NTI number to process the claim. So yeah, I think overall this is a really great idea and would be really helpful for supporting pharmacists in doing their job and reducing the confusion that they have, and then streamlining the process for consumers as well.
Looks like there's another raised hand. Sabrina?
Yes, hi.
Mhm.
I just have a question. That's the information that was handed out by CVS Caremark. May I have a copy of that? Can I get access to that by chance?
I think we can distribute that to the collaborative members.
Okay,
Yes.
great. Thank you.
Yeah. Should have gone out with the prior meetings materials, but I will send it again.
Let me
That's
go
right.
through my materials before you do that.
Mhm.
I have it.
Okay. And Ariana?
Thank you so much. I'm not an official collaborative member, but I just want to make sure. It sounds like we just saw from or heard from Sabrina, which is great. I don't know if Samantha Ritter or Becca Lane, any of the other agency representatives have anything to weigh. I just want to make sure if we're moving forward with this recommendation and it impacts you, you all feel okay with it.
Samantha has her hand raised.
I'm happy to chime in. I was waiting to see if our Medicaid partners were on the call because I think they would probably play a more central role in this. Fine with the recommendation. It would be helpful as we get into the report to potentially clarify the different responsibilities of the state agencies. And so as long as there might be an opportunity to do that, I feel comfortable with this, again, from the public health side of the health department.
Okay, thank you.
Hi, speaking on behalf of MHBE. Yeah, I think this recommendation is a great idea. I don't think it would impact MHBE directly, but you know, we support yeah, putting the building blocks in place to implement the coverage requirements that are existing. So this is, I think, a great step.
Thank you.
Just an FYI for everyone, Joy had an appointment before this, Joy from Medicaid.
Mm.
It will be on. She's running a little bit late.
Okay. Any other feedback from the other stakeholders? I see some pharmacists on here. I see some of our PBM friends. If you'd like to provide any feedback. If not, we are moving quickly through this agenda. All right, I think we're going to vote on the recommendations once we've completed discussion of all of them. So if there aren't any other comments, I'll turn it over to Cynthia to review the recommendation 2.
Thanks. So a big part of the collaborative is also, as someone already said, making people aware that this is an option for them and how to avail themselves of it. So a draft recommendation on that point is the state should inform and educate Marylanders about OTC birth control access by activating all relevant existing partnerships and seeking out new partnerships within and outside of state government. And the thinking behind this, of course, is recognizing that public-private partnerships are really important for doing this work. But we wanted to emphasize the action and actually doing the informing and educating as opposed to just forming a partnership. So really taking advantage of the partnerships that already exist, but also recognizing that new partnerships can definitely be necessary and important as part of the informational and education work going forward. So this is to ensure that there's a focus on the consumer or public education, and that how we would do this and, you know, which part of the state and who all would be involved, all of that those would be details that would be discussed going forward. So that's the thinking behind this kind of more general high level recommendation. But we wanted to make sure that there was a recommendation recognizing all of the groups that might need to be involved in this process. So I'll open the floor for comments or questions about this recommendation. Okay. Is it Delia or Delia?
Yeah, Delia.
Delia, go ahead.
No, I love this recommendation. I'm an organizer on a college campus, and the Advocates for Youth, like, youth model for OTC. And I know having organized around OPIL on college campuses as a young person to other young people, there's not a lot of knowledge on OPIL yet. I think people see boxes next to, let's say, Plan B, which I think is much more in the cultural zeitgeist of meds that people can identify, but I think OPIL understanding for at least young people on college campuses, I think is, moderate so far from what I've seen and the organizing I've seen. So I think this recommendation is really exciting to be able to, bolster information about OTC and specifically OPIL for young people.
And I think that's something we'll get into next year is sort of how, the extent to which the work of the collaborative gets into those details, or whether that's something kind of worked out more at sort of the planning and tactic level within kind of the partnerships that emerge, right? I think that's kind of open for discussion. But thank you for that comment. Other comments or observations about this? Christina, go ahead.
Hi, Christina Pecora from the National Health Law Program. I also just wanted to plus one how vital this recommendation is, just because of the lack of education we've seen, or even in states that have this coverage. And I know that you had said we'll work out the details down the line, but I just, again, want to uplift that, ensure this education meets people where they are, especially the folks we know who can most benefit from this and who are really clamoring for this. So, like was said earlier, young folks, underserved communities, so that we're partnering with reproductive justice organizations, and that the education itself really meets folks where they are in terms of accessibility, and really in a way that they can understand. Thank you.
That comment. And yes, as somebody committed to health literacy and clear health communication, both of those comments really align with what I would like to see happen under this as well. Victoria, did you have your hand up?
Yes, I think just that I agree with what everyone else has said. I guess a clarifying question: is this recommendation specific to the public and general consumers, or does this also kind of get at the education that's also needed to educate pharmacists about this, and other kind of stakeholders that are going to be involved in potentially processing claims, like retailers, things like that? Or is the, those are
Yeah.
two different kind of audiences that we may need to be focused on.
That is a great point. And obviously, there's a lot of possible and really important audiences / stakeholder groups. So I'm going to actually ask Brett about, just from a process perspective, since this is an interim report with a short turnaround, Marylanders is intended to cover everyone, but we've heard about two kind of high priority audiences, or maybe more than two with Victoria's comment. Do you think for an interim report that your recommendation is we get into some of those specifics at this point, or is that something that you think that would be more appropriate for a more detailed report next year?
I think we can definitely get into sort of the context of what we mean by Marylanders and want to make sure that these folks are included. It probably won't form, unless we choose to, this collaborative can choose to add specific language to the recommendation. If approved as Ariana just added to the chat, general public, retailers, and pharmacists. So we can also add healthcare stakeholders, providers, all of these specific populations. We can add youth and young people. We can also add this as context to the recommendation. So we approve this with the understanding that Marylanders means the following individuals. So we can choose whether we want to add, that's why we have some discussion time. We can choose whether we want to amend this recommendation to specifically include these populations, or simply add it as context.
So that's super helpful. Do you think that with the way that you've seen these things formatted in the past, would there be potentially more focused kind of sub-recommendations? So more like 2A, 2B, like if we wanted to call out young people, we wanted to call out pharmacists, we wanted to call out healthcare, doctors, nurses, et cetera. Would it be more like a sub-recommendation, or like you said, more context?
I think we can go either way. There's a lot of variety in the reports that I've seen from similar commissions, I guess, or collaboratives.
Okay. All right. So we have comments about more specificity in some of the groups within Maryland we might want to prioritize or really call out to make sure they understand that they're an audience or group of interest to us. So we've got a couple of options. As Brett said, we can provide some context, some introduction to this recommendation, or we could create sub elements to it. So we could have like 2A, 2B, 2C, and then we could highlight some of the groups that have been mentioned that way. Does anyone have any particular preference about how that might go? I would say just from a plain language and ease, this is already kind of one very long sentence. And so if we add a string of different groups to this, it makes it even longer. So my preference is to not add that string of groups to the main recommendation. It would be to go with either the option of the context or to add the subcomponents if we want to highlight specific groups already as part of the interim report. So thoughts or comments about either or both? They're not exclusive. We can have both. We can have context and we can have sub recommendations. Aaliyah, go ahead.
Oops. Yeah, I was just thinking about wanting to clarify, but also, as you said, when we get into these long lists, we obviously end up missing people and it just becomes a lot. But it seems like there's 3 real partners. It's the state, the providers, and the public. And so this is saying the state should inform, and it's really the providers that need to be informed on the whole process, the availability, payment processing, all those things we talked about in the first recommendation. And then the second one is the public, and that could be anybody. And then I think we can further define that later. But that would clarify who needs to be aware of it, and not get into students and this group and that group and everything. Just an option for a high level.
And just for ease, I've just added these options to our polling function, which was how we'll be sharing our preferences on how to move forward on these recommendations, so we can record folks' thoughts if you're not comfortable speaking up.
That would be great. Yeah. So here's my take as a communicator, is sometimes a little bit more specificity helps people realize, oh, yes, I am in that bucket, because sometimes, public is just so broad. And the reality is there's only people within a certain age range, right, who really need this information the most, right? We have people who are much older, who are, maybe they want to talk to their, talk to other people about it, but they're not the primary users of the product. So I think, if we're thinking about the reality, the kind of the harsh realities of informing people, I spend a lot of my time on trying to help people promote information and products and services. And so, it's a huge challenge, is that I think if we want to have more specificity, so the providers, for example, know, but I'm guessing that the conversations that healthcare providers are having are different from some of the things that people have been suggesting what would happen in a retail pharmacy context, for example. So even healthcare providers is kind of a really big bucket to maybe not everybody would see themselves in that, or the retail pharmacy might not see what is their special role in the way that they, kind of sign and promote and position these things to make it more obvious, sort of what the product is. So with that, I think, it would be good to kind of maybe just take a sense of the room, if we could have the polling function and just see if people are leaning one way or the other, because even if it's not including everybody at this point, if we went with like the ABCD option, we could at least call out those really high priority groups that we think the collaborative and the state should focus on going into 2026. Is there another hand up? Am I missing a hand?
We have a couple of comments in the chat, but I don't think any hands are currently up.
Okay. So could we go ahead and activate the polling, Brett, and just kind of take a sense of the room?
Yes, we can. All right, so I'm going to launch both questions regarding each recommendation. And it should appear that you are able to vote.
my first time using polling within Google Meet, so kind of interesting to see how it works.
As chairs, do we vote? Yes, okay.
Absolutely, yes, all members.
Okay.
And I know we have some folks who are stepping in for other members today. If you are comfortable voting, fantastic. If you prefer that the person appointed vote instead, we can contact them after the meeting. Go ahead. Sorry, go ahead, Penny.
I just had a question. I'm not familiar at all with Google Meet. I'm not sure how to vote on this. Like a little banner came up and then it disappeared. So.
Mhm.
Hey Brett, it's Joe. I'm mobile and I can't really see the poll, but I'm happy to provide my responses offline if that's useful.
Sure, yeah. So I mean, I can read aloud for folks who can't see them, and then if you would like to put them in the chat or email me and our co-chairs directly. So recommendation 1 on billing guidance. Oh, go ahead, Aaliyah.
Before you get into that, so if you are on the computer, if you go to the bottom right-hand corner, the square that has 3 dots across and 3 down, if you click on that, it will open up the meeting tools and then you'll see the polls at the top and you click there.
Perfect. Thank you.
Okay.
Thank you, Aaliyah.
Mhm.
Okay, so our first recommendation on billing guidance, the options are to approve as finalized, which would be in its current form. I don't think we had any changes for that one, or to table that for 2026. So that is the option for that. And then for public education and partnerships, our second recommendation that we've been discussing, the options are to approve as written with specific populations included as context within the report, to table this recommendation for 2026, or to amend to add specific populations as sub-recommendations.
Ariana, go ahead.
Thank you. I just wanted to clarify. I think you went over this last time, Brett, but collaborative members are going to have, when you say the option of adding subpopulations as context, collaborative members will have the opportunity to review that, right, and give feedback. So just wanted to clarify that process.
Yes, thank you, Ariana. And we'll talk a little bit more about the report after we finish voting. But yes, there will be the opportunity to look at, especially this section, in December before we submit the report.
And yeah. So I guess why don't we? Is everyone done voting or sending in their comments if they couldn't use the polling function? Okay. Let's see what we've got, Brett.
All right. So closing these now. We have 10 votes to approve the billing guidance as finalized. So it sounds like we will be including recommendation 1. I will go back to that one so you can see it. And then we will, yes, get into more detail in the next year before submitting our final report regarding how each of these agencies works on this and what should be included in that guidance. And then we received 7 votes to amend recommendation number 2 to add specific populations as sub-recommendations, and 5 votes to approve it as written with specific populations as context. So I will be adding sub-recommendations, and then folks will be able to submit comments and feedback on those sub-recommendations.
And just to kind of recap, what we heard were young people, young adults being a priority population. We heard pharmacists, both retail and in other contexts, other healthcare providers. Were there any other priority populations that people mentioned that I missed? Insurers themselves, or are they covered more by the guidance under number 1? Because insurers do their own communication with their beneficiaries. So it might be helpful to include insurers also. I know I get lots of communications from my insurer. Okay.
I agree with adding insureds and maybe PBMs as well. Maybe there's a way to describe maybe just communities that face systemic barriers or face barriers to contraception. That's a little broad, but thinking about people who could benefit the most from over-the-counter insurance coverage.
Great. Well, Brett, Aaliyah, and I will take a stab at drafting a revised version of this, and the collaborative will see it, as Brett said before, or as part of the draft report. Okay. All right. I think that takes us through the 2 draft discussions that we have. So we've done the polling, and I'm going to turn it back over to Brett.
Ariana.
Sorry, I noticed that Joy from Medicaid just hopped on. So if we want to draw her attention to the recommendation we just approved that does affect her, I might be good.
Thank you. Joy, welcome. We just voted on these, but would love your feedback and your vote as well on these 2 recommendations, one of which will directly affect Medicaid as it is named in the recommendation. That is recommendation 1 that I just added on the slides. If it's helpful for me to read it, I'm not sure if you're able to see the slides from where you're joining.
Sure, I can see it.
Okay, great.
Pulling me in.
Of course. Thank you, Ariana, for pointing out that you were just able to hop on. So it would ask state agencies to advance guidance with a consistent billing method for insurance coverage of OTC products. And then we would, in the next year, get more into the weeds, into the details, as Samantha also from MDH brought up, on the role of each of these departments, the role of the Insurance Administration, Department of Health, specifically the Medicaid program and the State Employee Health Program, to create and put forth these pieces of guidance, and what should be included in that guidance as well. We'll get more into that later on. These are just our interim recommendations to submit this year.
It sounds good. Thanks. I think, as I mentioned before, there's slight differences which come up administratively and billing wise between Medicaid fee-for-service and the MCOs. The MCOs have more of a way to enforce consistency within them, in that we have monthly meetings with them. Fee-for-service is sometimes its own does its own thing, but we can certainly work to keep the 2 branches cohesive in their administration of this.
Thank you. Sorry, just writing that down. And then our second recommendation, which we just voted to actually add some sub-recommendations within this recommendation regarding educating Marylanders to ensure that we're capturing specific populations that are priority populations. So looking at so as Aaliyah said, sort of overall buckets would be the state, providers, and the public. And then within that, to look under providers, we would specifically be looking at pharmacists, physicians and advanced practice clinicians, and insurers and PBMs. And I'm sure Medicaid will also be playing a role as a state agency in ensuring that the MCOs, the fee-for-service beneficiaries, all know what's going on in the world of Medicaid. And then in the public, we were looking at young adults and then communities that have faced and continue to face barriers to contraception. So it is a little bit general, as Victoria said, but for now, especially keeping it general, will capture a larger population.
Sounds good. Thanks.
Fantastic. Okay. So I believe, yes, we will have those sub recommendations included in the draft report. I will make sure to highlight and call your attention to it because we do specifically want feedback there that hopefully everyone will be able to take a look when that happens. Are we ready to move to, again, just a reminder of what's coming with the interim report and then a little bit of a preview of the exciting work of next year?
Yes, I think so.
Great. All right, so this is a reminder, this is the same slide as our last meeting, that you will have the opportunity to take a look at, especially this, but the full recommendation section and discussion of the meetings during this window of December 8th through 15th, hopefully before folks are heading out for end of the year travel. The report is due to the legislature by January 1st. We are trying to get in well before that deadline. So this is what we are looking at now. If you already know that this isn't going to be a window that works for you, please do reach out. We want to make this as accessible as possible for folks to review. Are there any questions here? All right, hearing none. So we're looking ahead to 2026, which is going to be our very busy year. This is our 2-year project. So as we complete year 1, are looking at year 2, we have some upcoming work that is described in the statute that created the collaborative, which is reviewing some federal comments and federal proposed, sadly not finalized, regulations that would have created over-the-counter coverage on a national level, as well as looking at the Free the Pill report. As required in our statute, we'll be having some presentations, most likely from Free the Pill, and looking at point of sale coverage and access. So that is not having to go to the pharmacy counter to hopefully get coverage without cost sharing for over-the-counter medications. So to be able to purchase them at the cashier the way we would buy a bottle of Tylenol and still be able to get that coverage. So we're looking at the feasibility of that and some ways of getting that done. And again, we will have presentations there as well. We will be talking a lot about public and stakeholder education. So really getting it much deeper into what we just talked about with our second recommendation for the interim report, and then some public health programs for consumers not covered under the Contraceptive Equity Act that created over-the-counter coverage. So folks who are uninsured, for example, or whose plans do not fall under state regulation. Are really some of our target audiences there. And then we will be putting together our final reports. So are there any questions, comments, points of clarification? I know this is general, but this is sort of the arc of what we're looking at for next year.
I don't see any comments. Do either of you? Okay. All right. So again, just to reiterate what Brett said, the window of review is going to be December 8th through 15th. So if that's not a week that works for you, please let us know ASAP so we can work with you on how to get your feedback. Yeah, and I think that's all we had on our agenda, unless anything else, Ariana or Brett, that you know of?
Not at this time. If folks have, again, topic areas that you want to discuss next year, if you have presenters that you think we should hear from, we want this to be, it's a collaborative, so we want this to be as collaborative as possible and include as many folks as possible. So, you know, please do reach out with agenda items, with questions you have, with folks we should hear from, documents we should look at, all of that. We really do want this to be as collaborative as possible.
Mm-hmm.
Aaliyah, any final words from you?
I was actually about to say the same thing that Brett did. I just wanted to make sure that we, what we talked about today captured this discussion that we've had so far, and that if people have additional comments or areas that we need to focus on, to, you know, please speak up, because we want to make sure that this is a comprehensive report and thoughtful and respectful of all the communities and stakeholders that we're trying to reach. So thank you.
All right. Well, thank you everyone for being so efficient about today's meeting. I'm sure everyone's really happy to get some extra time back in their afternoon. And you'll be hearing from us with a draft report. Oh, lunch. Yes. A lunch is always a good thing.
Yes.
Okay. All right. Thank you, everyone. We will see you soon.
Thank you.
Thank you.
Thanks, Brett.